Okay, let's go ahead. So welcome everyone, and we should be here for the next 90 minutes. And this is part of a series that we've been doing to describe some of the chapters that we have in the GIN Public Toolkit. And this session is going to be about how to include research about patient public views in guidelines, in clinical practice guidelines, public health guidelines, any type of guideline. And we are hoping that we can make this as interactive as we can. Hopefully, if you can use the chat, that's great. Feel free to jump in, ask a question, or share an experience using the speaking function and unmute yourself. And feel also free to put up your hand. We'll be making sure to check on the whether you have your hand up, and would love to hear from you. Okay, so I'm Nancy Centesso. Just briefly, I'm based in Canada at the McMaster University, and have been working with Luba, who I'll just have introduced in a second, and other people on the chapter about how to include research about patient and public views in guidelines. So we'll go through that chapter a bit, give some extra examples as well. Luba, did you want to introduce yourself too?
Sure, I'll just do a quick introduction. Thanks, Nancy. Hi, everyone. My name is Luba. I'm a PhD candidate at McMaster University, working with Dr. Gordon Guyatt. My interest is in patient public involvement in clinical practice guideline development and stakeholder involvement in general. And this is a really great project to work on with Nancy. I've done some systematic reviews of values and preferences and research related to this topic. So happy to chat about that.
Good, great. Okay. So again, as I said, this is coming from the GIN Public Toolkit. It is one of the chapters, chapter 2, about how to use research for about patient public views in clinical practice guideline development, how to use that evidence or research articles, etc. And you'll notice just along the side, on the right-hand side, when you go into the whole GIN Public Toolkit, there's lots of other chapters about how to consult with patients in the public, how to do systematic reviews, how to use patient information or create patient information based on clinical practice guidelines, or even how to create decision aids. So there has been 2 other workshops, and maybe you were able to attend that, describing some of these other factors and parts of including patients and the public in clinical practice guideline development in general. So we will focus on using research created for that. So today, what we'd really like to do is guide you through the steps, and also making decisions about how to include this type of research in making recommendations or decisions. And again, it could be in a public health type of clinical practice guideline, or a very individual clinical practice guideline, or even at a public policy coverage decisions, any type of recommendation actually. And we'd like to provide some examples and also hear from you too. Now, I just know that there seems to be a bit of background right now. Maybe someone joined and needs to mute, maybe?
I'll check through.
Okay, great. Sounds okay now though. Good. So just as a framework to start out with, we're going to use the GIN McMaster guideline development process to structure what we're going to talk about during this session. And just stepping back and looking at this figure, there are many steps to the guideline process, which I'm sure a lot of you know and have been involved in many of those steps. But as we said, there's a whole chapter around how to include patients, the public, in the process. So we're not going to cover actually physically including those people in the process. So we won't cover that part, but certainly very important. The next part is there's going to be, even when you're involving all of those people, you'll need to think about conflicts of interest and how that could affect the guideline process and how to manage those conflicts of interest. So we won't cover that also. Again, it's part of another chapter about including patients in the public. Of course, there's the planning stage of the entire guideline development process and also training. So this also is provided in another chapter about how you might train the public before participating in a guideline process. So we won't cover that, but there's certainly information in the GIN Public Toolkit about that. And we're going to skip over this first part of the guideline development process where you set priorities about what guideline in general your group wants to do and selecting a basic topic. So we're going to talk about cervical cancer. So that would be sort of our broad topic. But again, patients in the public can be involved in that part. We'll get into more of the details of the specific questions in a guideline, but making that decision at a very organizational level, we won't go into that. Again, this usually happens at a very like a meta high level point of what type of guideline topic that we would cover in general. So we'll skip over that part. And this is where we're going to focus most of our attention today. Very specifics about what types of recommendations are we going to include in the guidelines. So this PICO or question generation. We're also going to focus on the evidence that we would collect. We'll talk about treatments, tests, screening, values and preferences, also issues related to resource use, equity, acceptability, whether it's feasible, and also on these green parts about developing the recommendation and how to include research from patients and publics to be able to do really what's in this black box right here. So we're not saying that the rest isn't important, but we can get a lot of information from research, specifically in these few processes. Okay, and then very first question that we're usually asked, even before we jump into the workshop, is what do we mean by using research for patients in the public? And we really are being quite broad in what we mean by research. So it could be what we typically think of, what's peer-reviewed and published in the literature, published in journals and articles. Of course, that's the type of research we would like to have, but we are also would like to see if it's available, if there's research from reports or data from evaluations or investigations that might be provided or done by different organizations, different groups, and those may not be published in the typical Medline database or Embase database or published in a peer-reviewed journal. But that type of research is absolutely important to look for, and we would like to include that type of research too. And then we'll get into more details about this, but when we say research, we don't just mean that, the very right-hand side there. We don't just mean randomized controlled trials and non-randomized studies. That's not just the research we're talking about. We can talk about including research from qualitative studies, so focus groups, interviews, other documents, surveys, different types of study designs that may be looking at the importance of an effect. So that we'll talk about minimally important differences. Studies that are measuring utility or non-utility, which gets into a little bit of economic analyses, and then our typical comparative studies such as randomized or non-randomized studies. So we're talking about any type of research here, any study design. And also it could be reviews of any type of study design too. And it could be systematic reviews or reviews in other people's guidelines, other organizations who've produced guidelines. Any questions about this so far? So that will be our focus. Luba, I don't know if you wanted to say anything else or add anything, but if anyone has some questions about this, please enter it in the chat or put up your hand and speak up.
I guess I just wanted to make a note, and I'm sure this will come up during the presentation, is that there's a lot of variability in what people consider to be research related to values and preferences, and like research related to kind of like preference sensitive decisions. So it's less of kind of a systematic approach that you might see people take on just because there isn't really like strict guidance about it, even in terms of like the kinds of study designs you include, the kinds of research questions they're asking, that kind of thing. So it's less strict in that way. Janice asks MIDs minimally important differences.
Yes, yes. Is that okay? Oh, now I'm going in the
Yeah,
wrong.
that's fine. I forgot what the D was for. We've used it in guidelines anyway, because often I just want to add on that public and patients often what might be determined what's the most important, to individual patients or public individuals. One of the, whatever the differences might actually make a big difference in their life, right? Like, yeah, so it can be different in talking with people and explaining why certain outcomes or whatever are chosen over others is important to discuss.
Absolutely. Great. And we'll spend more time talking about that. So that's an excellent point. Thanks. Okay, good. So one of the things that Luba and I, when we were going through this and even when we were writing the chapter, was trying to give ideas of where information or research about patient and public views can be used. And because I think many times a lot of times we focus on one part, even myself, as we're going through, we might focus on, oh, I'm just going to look for evidence or research in this one area. But there really are multiple points during the guideline process where research and the views of patients could really inform the process. So one of our goals of today was, let's make sure we have a conversation about all the different points that we can contribute and have some valuable input into the process from patient public views. And then another tricky part was, how do we use that research? How do we summarize it? How could we assess it? Should we assess it? How could we present it? And exactly that, how do we present it to the guideline developers so that they use it? Because we can gather together tons and tons of research, but if it's not in a usable way, the guideline developers may ignore it because it's just not in a good form that they can use. Okay, so let's start. As I said at the beginning, we're going to start at question generation. And didn't want to spend a lot of time on this area, but certainly important. And I think what we'll find is that depending on your topic area, there may be a lot of research available or maybe not as much. And you may actually need to conduct your own research to do it. And again, there's another chapter of how you might conduct and include patients and public when you're doing your own research. But let's focus on what we could use of research that's already out there and how we could use it. So generally, I'm going to focus on an example for the rest of the workshop. And the example is around recommendations for screening to prevent cervical cancer. So this was a real guideline that I was working on, and the organization had decided, and the World Health Organization decided, we need to do some guidelines about screening to prevent cervical cancer. And at that point, we needed to decide, okay, what are all the questions that we need to cover in this recommendation? What's going to be important to decision makers? And I'm going to put out to you how and we had our process of how we did it, but what would be one way to ensure that we use research or find research or look for research so that we make sure that we're asking the right questions, questions that are important to patients, important to the population who we would screen for cervical cancer. So what type of research might we look for to find out what are the important questions? And, think also back to maybe if you've worked on a guideline, how did you come up with the questions and make sure that they were important to patients? So if you can add it to the chat or raise your hand, that's great. So I'll just give you a couple seconds to think about that. So what type of research might we look for to decide what are the important questions? Some ideas. Luba, go ahead. You have your hand up, but go ahead.
If people are quiet, I'll just raise my hand. Yeah, one of the things that we used are the priority setting exercises, like the James Lind Alliance ones, because they're very rigorously developed and address important issues. So I was part of a guideline on diabetes where we pulled some questions from there. The way that they're structured for the top 10 priorities tends to be quite vague a lot of the time, because they're really trying to condense 100 people's responses into a couple sentences. But we still found that it was useful, and at least we could say that we referenced the document.
Yeah. Luba, would you be able to put the link? I have a slide on that, but I don't actually have the link to it. I don't know if you could put the link.
Sure, yeah.
Yeah.
I'll pull it up. So there's 2 comments here. Janice says surveys, focus groups, and community gatherings. And Jacob says qualitative studies, e.g. interviewing patients, and use grounded theory to identify common themes in interviews.
Great, great. So yeah, so both of you had mentioned the qualitative studies where we're hearing from patients, and it would be great to be able to find those types of studies to help to inform the guideline group about what are important questions. And also surveys for sure. Janice, I wonder if you might say something about community gatherings.
Yes, thank you. So here in, there's been a very fast movement, to back up a bit, regarding involving patients, partners in research and beyond. And I know the UK is pretty much implemented across the board, as well as having compensation. And in the United States, we're a little bit farther behind on evidence involvement. But what we perhaps are advanced in, and there's many other places that are, is involving people we call with lived experience and having, like the gentleman mentioned, where we have interviewing, but basically there's sort of large focus groups where leadership might come to this group, which is primarily individuals of different backgrounds, Native Americans, African Americans, Latinos, different individuals that have not traditionally been or institutionally been involved. And so having them provide their perspectives is really important to, get a common ground. And also, I think something like prioritization, if you make a word cloud with a community gathering, or you have a Zoom meeting and have everybody put in a couple words, you're going to have ideas, or, 3, what's the most important. You're going to receive information from differing groups fairly easily that way. Thank you.
Absolutely. Yes. And
mentee or whatever. Yeah.
Yes. Yeah. I can see other people. It's these people with experiences can share their preferences, their values, their experiences here. Yes, again, and things that are important to them, satisfaction, etc. From Christine too. So that's great. Yeah,
also,
so that
also I want to mention, it's different, cervical cancer in the African American community. I do know that there's been a big push here in my state, Washington State, University of Washington. We have some very good researchers, but there often have not been included, or 1 or 2 people. So reaching out to those groups and finding out what their priorities are, and follow up with within the groups that are have been traditionally underrepresented.
Yeah, and that's a good point, Janice. We're going to get to that. Hold on. So we did, also same as all of you have said, there are these different types of researches that we can use. So we could use results from surveys that have been done or questionnaires that have been done, traditional qualitative research like focus groups and interviews. And, I think close to this community gathering is also through online chats. So through organizations that have they have these open forums, and a lot of literature is being done these days around analyzing what's coming out of these documents, electronic documents, these health forums. So I think we do have to be broad about what we mean by research. And again, moving beyond just what's published in PubMed or Medline or Embase. And again, we could find systematic reviews of this type of research studies that have already been done too. So that's great. As I said, if you're going to conduct your own research or work with advisory committees, that's covered in another chapter. And so you could do your own research, but it would be great to see what other research is there out there too. And I just put a couple examples here. And if you've looked at the GIN Public Toolkit, the chapter 2, we also referred to some of these examples, but this one, it was a project that I worked on, and it was for osteoporosis and preventing fractures. So a different example from cervical cancer. But what we did is there was some, we did do a primary research, and did a survey with 1,000 people, across 1,000 people in a patient group around osteoporosis. The research here was mailing out to the members and getting their feedback. And so you could imagine if I'm someone else doing, and we published this, if I'm someone else doing an osteoporosis guideline, I could look for these types of surveys that have been published. And what I could find in these types of research is, for example, what this survey told us was that people were focused on and prioritized wanting to know about physical activity and exercise. They wanted to know how to prevent falls, not just how to deal with it once they had a fall. They wanted to know about nutrition and also about how you might test for osteoporosis. So this type of research, if it's available, can certainly provide some information about what you as a group might prioritize later. And then, as Luba mentioned, I just had a screen capture of the James Lind Alliance. This group, they have groups that are conducting the research already for you and posting what are some top priority topics within a subject area. So Luba had also put the link to the James Lind Alliance. So this, again, it's not published, it may be published in the literature, but it's also rigorous research that has been done. And I would collect this from this website. So we did do this for cervical cancer, actually. We did a search in the literature for studies that reported the results of focus groups in women, interviews, surveys. We looked for those types of studies. And based on our search, we found studies that reported the results of focus groups in women who were cervical cancer survivors. So already had been screened and went through and had cervical cancer and had treatment. And from those studies, we found 4 key themes, and those themes were the importance of being screened. So that was a top topic, I guess. There was confusion about what screening tests are available, which tests are better. Another theme was the lack of information about the pathway to take, what happens after you screen positive. And there were a lot of comments made about options for treatment and possible side effects. So those were the 4 key themes that came out of the research. So we looked for the research. This is what we found. The question is, so here we found this, we looked for it. How certain are we that these are the top priorities? How can we be certain? We're going to take this information, we're going to feed it back to the guideline group and say, these were the themes that we found of the top priorities. There were focus groups done in women who were cervical cancer survivors. And, should we say to the guideline group, this is what we found, this is what people find that is important, or we think that this is what people think is important? What do you think? How could we, should we give some indicator of certainty? What could we use to actually determine that? So Heba, you've put a few things in the chat there. I don't know if you want to say anything about that.
Yeah, I mean, maybe the sample size of these studies can tell us something, and also the variability. So if we have large sample size and variable groups, maybe it's more informative.
Yeah, so if you hear from more people, more, and I'm thinking about the variability. When you say variability, do you mean like different populations? Is that what you mean?
Yeah, like
Okay.
different ethnicity, for example, different races.
Yeah. Yeah. Other thoughts from people? Should we be so sure that these are the top priorities, in fact? Should we be a bit cautious? Is there something you'd want to know a little bit more about in these focus groups?
This is Janice. I have a quick question. Isn't HPV testing, that's one of the tests for cervical cancer, right?
Yes, it is.
So I have found it interesting. I don't know if you know what diethylstilbestrol. It was a drug that was given to mothers in the 60s, 70s, and they know the daughters have a much higher chance of having a rare cervical cancer.
Yeah.
And the test they're still giving though is HPV, right? And so I think there's some pushback, in all honesty, in some populations that it's somewhat of a stigma, right? The HPV, if it's when it's associated with the HPV, and so it's just something to think about.
Right. So, one question would be, are there a lot of people that would be interested in finding out more about the HPV test, for example? So do we need to have a recommendation around that? It might be good to have some research around that. And, did that not come out here? And why not? Why didn't it come out? Maybe we didn't include the right or a good variability of people. Yeah. Fabiola, I think you also said about the population, some concern about, who were in these studies. Did everyone have a chance of being screened, or were they screened? Was it people who were screened actually? And then Jacob, important to consider health equity and access. What do you mean by that? What would be something?
Oh, I was just thinking that considering like access to the screening for people who might be in lower SES communities, and also I was thinking of the just taking into the cultural aspects of someone with HPV, and this is not entirely specific to HPV, but I'm thinking like in a general broad framework, like considering the equitable access, especially to the screening.
Absolutely. I mean, I think it keeps going back to, who were these people in these studies? Did they include people with low SES or not? We need more information about that. And if it didn't, maybe we're not going to be so sure that this really is representative of who was screened or who's providing this information about the important questions that should be asked. Yeah, yeah. Luba, did you put your hand up?
Yeah, I just have a note. This is like a very like eternal question in terms of whose preferences to include is people with lived experience of a condition, particularly depending on like how rare or common it is, versus people who are at risk of the condition who haven't had who haven't been diagnosed and haven't had a procedure, for example. So that's an important consideration as well as your selection criteria.
Right. So is this maybe going to be a little biased because we've included cervical cancer survivors in this? Maybe we should have included people who have never been screened before, or who've never had cervical cancer. And so that might give us a different perspective, actually. And maybe they would have different questions that they think are more important. Absolutely. So we do kind of keep going back to who's included in these studies. We had a few comments about the number of people in these studies, how different they were from each other. So that's pretty important. Someone had mentioned just how well done these studies, the methods of the studies are. So that's pretty important. So we had the number of people. The reason I asked was because many times we'll present this type of information or research to guideline groups and not give an idea of how certain we are about the information that we've provided. I think, we've spent a lot of time on, how sure and the certainty of evidence and grade for benefits and harms. But we haven't spent enough time on thinking about these the other information or research that can come from patients and the public, and how good is that research to inform our decisions. And so, I just wanted to make sure to mention to people that just because it's not about benefits and harms, and we're not coming up with these numbers, that there still is a way that we should be informing the guideline group about how sure we are about the research that we found to inform our decisions. And just, there's a little bit more in the chapter about how to assess the evidence we find, for example, in priority questions. And there are different systems, but we do get the example of CIRQUAL. So it is based on grade, and it's about the certainty of evidence in qualitative research. So if we're looking at those focus groups and interviews, and we're coming up with themes, we might want to tell the guideline group how certain are we about those themes that came out. And it does cover the points that everybody brought up. So, just in general, how good were those studies? What were the methods? So the methodological limitations. And then a big one was this relevance. So if it's coming from people who are not necessarily having lived experiences or not at risk, how relevant is the information from those groups? So that's another component we really covered. One that we touched on a little bit was the coherence, and basically it's saying that, even across populations, so if we had a lot of different populations, variable populations, did we seem to come up with themes that were the same and similar across these groups and across the studies? So if there's some coherence across those studies, probably more believable. You know what, this keeps on coming up in the studies. And then we did touch on how many people were on the studies. How rich do we think that data is when we talk about qualitative research? And we just talk about the adequacy of that information. So we're not really talking about necessarily sample sizes, but how adequate is that information we obtained from the studies? I don't know if have some people used CIRQUAL before to assess qualitative research before? No, a couple people know. If anyone's used CIRQUAL before. So have a look. Actually, Luba, maybe you could put the link to the website there for CERQUAL in the chat. So Christine has used it, yes, at the Registered Nurses Association of Ontario. So yes, Christine, did you use it with qualitative research kind of like this then?
Yeah, we did. So when we do our systematic reviews, we usually include qualitative research as well as quantitative, and then use CERQUAL to assess the qualitative research.
Of that evidence. Excellent. Great. Good. So it is an option. And I would even say if you're not going to use an official or a formal system, you probably will still go back to the guideline panel and say, you know, these are the types of studies we found. This is, you know, the type of people it came from. So you're still giving an indicator of these domains, I guess you could say, of how good you think that research is, and giving just an idea to the guideline group. Excellent. Okay, good. So the other thing, you know, is that CERQUAL will just provide you can sum it all up in one category as I have high confidence that the findings that I found from the research represents the phenomenon of interest. So represents priorities in cervical cancer. Is there moderate confidence, or you have low confidence or very low confidence? And again, it'd be great to be able to provide this one final assessment, but I really do believe that it's even just as important to provide to the guideline group, if you're not using a formal system, indicators for each of these types of information, so they can also think about and judge it for themselves as well. So great. Good. And so that was just about how to come up with important questions when you're deciding what you're going to cover in your guideline. When you start to get a bit more specific and decide, okay, this is the question I'm going to ask, then you'll also want to decide what are the important outcomes or effects of that test or that treatment. And how do we decide what are the outcomes that are important? It's quite similar to when we're deciding on whether there are questions that are important. So again, the type of studies that you would include would be, as we said, focus groups, surveys, interviews, other information from documents or systematic reviews of those studies. The only thing I wanted to mention a little bit more about was when you're looking for information about what outcomes or effects might be important, say for example from screening for cervical cancer, something that there are just a little bit of a different type of study that is more and more being published, and there's studies that are referring to the utility or disutility of an outcome. And what we mean by that is again, it's almost loosely based on the importance of that outcome, but also about how much value or weight you put on that outcome. So for example, I just listed there's these non-utility studies and utility studies. The utility studies, just as an example, would say, they might show someone a scale and say, if you had major bleeding after treatment for cervical cancer, how would you rate that on a scale of 0 to 1, where 0 is something that's similar to death, or 1 is being in best health? And so they're doing these types of studies where they ask people to rate that on a scale. They average them out and then come up with a value at the end. And so in this way, we might be able to say, oh, if it's something that's close to death, it's very, very important. And this is an outcome that we would make a priority to cover in our guideline. So it's just a slightly different type of study design that we could use to inform the priority of outcomes. But again, the type of research that you can have for outcomes is very similar to the type of research you might use for prioritizing questions. So it's just slightly different, or an additional type of studies. And more, they're being done more and more. They're not always available in a lot of topic areas, but can be used. So it's just worth mentioning also. Okay. Any other questions about using research for identifying questions or outcomes? Yep, Janice just put, it can be somewhat subjective to the population. And I think that's very true. It's why we would then go back to the guideline group and say, oh, this study was only done in this population. This study was done in this population. How can we use that evidence? And is it enough to use? Is there do we have high confidence in it because it only includes this population, for example? And per individual's conditions. Yeah, so it can be quite subjective, but that's what we need from people. We need their opinions from patient, which is why we're trying to obtain patient views. Absolutely. Okay. So let's move on to the other stages in the development process. And I'm going to focus on, in this next part, on using information from mostly about information about benefits and harms. And we'll also talk about values and preferences and the other resource cost and use, etc. Okay, so let's focus on one question, and then I'll just ask you to think about something for a little bit as we go forward. So say, for example, our scope was, around preventing cervical cancer. We've decided that, a top priority question is, should women between the ages of 20 and 30 years be screened to prevent cervical cancer? So we want to know about when we should start screening women in order to prevent cervical cancer. So that's our question. Now, if I can just get you for a minute or so, just to think about, if we were part of the guideline group, what type of information would we need to be able to decide whether we should be screening at the age of 20 to 30 years? So just take a minute to think about what information you might gather together for your guideline group. Yeah, we have quite a few different types of considerations. Yeah, the cost, the risks, the baseline risk in different groups. Yeah. The accuracy of the test. So someone had mentioned the HPV test before. Is it a very accurate test? Might we have some false positives? Could people be falsely told that they have a cervical cancer lesion, but they don't because of the test and how accurate the test is? Yeah, baseline risks, benefits and harms. Yeah, preferences. Yeah, what are the pros and cons of screening? What are those benefits and harms that we would need, the guideline group would need to weigh to make that decision? Yeah, so I think, Alina put in overdiagnosis. Yeah, we've screened you, we say you're positive, but in fact, you actually aren't positive. We may even treat you based on that test when in fact, you're not positive. Or, and I'll just mention this, and someone, Greg, yes, natural history of the lesions in this group. That's what also is a really interesting question in guideline groups is, Okay, so we screen you. We think you have a lesion. It looks like it might change into cervical cancer, but it may not progress to cervical cancer. So how quickly could this happen? Or is it possible that the lesion fixes itself? And this does happen. Yeah. So preferences of patients about whether to be screened or not in general. And the costs, absolutely. So really great that people came up with all of these factors, because in general, this is what we know that guideline groups generally need information about. So I've just put it out here. You can see here we talk about the benefits and harms. We also have lots here about the resources and costs, absolutely. And then all of these other factors, such as, what are the values that people place on these benefits and harms? Do they value prevention of cervical cancer? How feasible is it to do this screening? Do people want to be screened or not? As someone had mentioned also in the chat. So we kind of generally call that acceptability of being screened or not. And any equity issues, who has access to these screening tests or not? Yeah, cultural issues. For some people, it may not be acceptable at all in their culture, for example. So most of the time, criteria can fall into these categories. And that's, the main category that we can discuss now: benefits and harms and value. So the question is, and this is where a lot of research is starting to be really done nowadays, is in how much value do people put in the pros and cons, the benefits and harms of doing screening. So here's the main focus. This has really been a big focus in what we know for patient using research. Heba, you had your hand up. Did you want to say something before we go forward?
Yes, I have a question. I face this when I'm on a panel. So we have patient values and the preferences, but they overlap with the other factors or domains like visibility and benefits and values.
So it's a good question. So let's see how, we can be a little bit more specific about what we mean by values and how we distinguish this from the other parts. Yeah, good question.
I have the same problem when I am doing evidence to decision table.
Absolutely. Yeah. Okay, so let's really discuss that. Okay, so let's say that some of the outcomes that people prioritized as important are, okay, so on the right-hand side, people want to make sure that it's preventing cervical cancer in the future. That's, top outcome, for example. Some other important outcomes, they want to prevent, if they have a lesion, they want to know that by screening, we're going to prevent them from going further. So not necessarily cervical cancer, but to something more serious, the progression. They also want to know, if we're going to screen and someone screens positive, they're going to need to be treated. So throughout the screening, the whole process, we still have some harms of treatment. And this will be really important in a second. You might have discomfort from the treatment. The treatment may actually cause infertility. So we know this from some research. Treatment may cause pain. The other issue is, though, and we mentioned this about the accuracy of the tests. If a test is not all that accurate, it may mean that a lot of women may be told that they have a lesion and have to undergo treatment, but in fact, they didn't have a lesion. So these false positives. And so the harms of treatment become even more important. So here are these women that are being treated who really didn't need to be treated. And now they're going to have harms from that treatment that they didn't need. So that's pretty important. And also important, and this is really coming out of our real guideline, was that people were concerned about, okay, if we do this test and we do all this screening, is it still going to miss a lot of people who actually have lesions and needed treatment? So we want to balance these missing people, but also unnecessarily treating people. Should we just not screen at all? So we have these benefits and harms. And we can weigh out, okay, there's 50 fewer. If we screen 1,000 women, there'll be 50 fewer cervical cancers. And we'll also find, we'll minimize, we'll have 100 fewer lesions that progress to more serious lesions. So not necessarily to cervical cancer, but progress to a serious lesion. So now we have these numbers of 50 and 100 on this side. So that's good. On the other side, though, is the negatives. Well, 100 women will be treated unnecessarily because we've now screened them and we falsely think that they actually have lesions. 50 women, though, will even miss 50 women, even if we do screen. And because some women were treated, 50 women will be unable to conceive because of the treatment, because of infertility. So the thing is, if we put a lot of value on those outcomes of preventing cervical cancer and the lesions from progressing, we're going to tip to actually recommend to do screening. On the opposite side, though, if we put more value on not treating women unnecessarily, on making sure that we don't cause women to have infertility, and more weight on possibly missing those women, we might actually recommend against screening. So it depends on, and so when we talk about values, we talk about the value that we place on those outcomes. And we could add up, well, 150 versus 200 issues is, 200 is actually more important, a higher number than 150, but it usually never works out where we can just count them up. What happens is this, even if there's, and then we can go backwards here, even though there's 150 things happening here, there's more value placed on those, and that beats and weighs heavier than the 200 things that are happening on the other side. So it really, really depends on the weight that you're putting on. And that is the type of information we want from patients and the public. How much weight do you put on preventing cervical cancer versus possibly not being able to conceive because you received a treatment that you really didn't need? Any thoughts about that, where the value comes from, why we would look for that? Luba, sure, go ahead.
I just wanted to flag that a lot of times you can ask people ahead of time what they expect to see before you can show them the evidence. Or you can show them the evidence and then get their votes. So those are two different approaches that you can kind of get those values and preferences. If you have potentially some research that has been done on like relative effectiveness or minimally important differences, this is also where you can use that research to inform potentially what those trade-offs might be. Yeah. So yes, absolutely. For us, I think one of the important things is gathering together this research about values, usually ahead of time, before we see the numbers. But it will help the guideline group when they're looking at those numbers to inform their decisions about what weighs more than the other in that trade-off, as someone had written in the chat. Okay, good. So again, the type of information the type of studies that you can get and look for, it's same thing. It's going to come from surveys, focus groups, interviews, chats, systematic reviews of those research. And again,
important to be able to assess that evidence. If it's coming from qualitative research, definitely you could go back to CirQual, but there's some research, new methods and new guidelines being developed just even within grade about how we might assess research that's specific to values. So again, we do we reference those resources in the handbook in the GIN Public Toolkit also. Okay, good. And here's an example. So we did a search, we looked for some studies, we found some qualitative studies. Young women may have a high level of anxiety related to side effects of treatment after screening. So more value placed on those side effects. Women place a greater value, again, on this risk of infertility with treatment. So side effects or adverse events versus the risk of cervical cancer in the future. So we did have this information from qualitative research, and then we did assess this evidence to let the guideline panel, okay, we found this research, but actually we do have low confidence or certainty in that evidence because some studies had some limitations in the methods of how they derived the themes, and they weren't very clear about what biases the researcher might have when they were doing the analysis. And most of the studies were conducted in women over 30 years. So not necessarily young women. So there's this concern about relevancy. So this is something that we would present to the guideline group to help them when they're making that decision about balancing the benefits and harms and thinking about what those values are. Okay, great. A couple more things, and Luba already mentioned this, and we had the question in the beginning about minimal important differences or thresholds. You know, the question is, what is the cutoff for how many women could have these side effects and it would be considered an important harm or not? So here, you know, 100 women, more women are treated unnecessarily. 50 women are missed. 50 women are unable to conceive. Where is our cutoff? You know, are we willing to accept 50 women out of 1,000, or are we willing to accept 100 women out of 1,000? And so we can obtain that type of information many times from studies that measure these minimal important differences or thresholds. Luba, did you have your hand up? Wanted to add something?
Yeah, I just wanted to mention, Alina had a great question in the chat. Values placed on outcomes versus clinical expertise. Where would the latter be positioned in deciding on a recommendation?
Yeah, it's a great question. So sometimes, you know, sometimes we do have this research about the values, and sometimes we don't. So I think the guideline group would come together and say, okay, that's great. We have some information about the values from this research. We have high confidence, we're low certainty or low confidence. At the end of the day, they do have to judge what value they're going to place on cervical cancer or on being unable to conceive. Of course, they should be informed by the research. Sometimes we don't have that research. And so sometimes that's going to have to just happen within the guideline panel, which we hope will be a representative guideline group. And they'll have to ultimately make the decision where they put the most value. The other really important thing is that the group indicate where they put that value. And they do that so that other people reading the guidelines say, okay, they put a lot of weight and value on cervical cancers. And they made the recommendation because of this. Okay, that's in our cultural setting, in our setting, we also put high value on that. So this recommendation applies to us. So even if we don't have that research, the guideline group who's representative, we hope, would still put their own value and make it clear where they place that value. Luba, did you want to add anything to that or?
Yeah, I guess like a kind of pragmatic comment is just like with a lot of other things, if the research seems to confirm what the panel thinks, like I think they're much more willing to kind of go with that. But then if the research is surprising, I think they'd probably check, you know, like kind of like look at the certainty levels more, or kind of like assess like why there's this discrepancy between what the research says and what the panel says.
Mhm.
And then so you make a great point about like, you know, is the panel the one that's like not very representative, or is it the studies that are not very representative?
Right.
And another great point that you made is the transparency of those decisions. So generally in the values and preferences section, and you know, where it's appropriate in other sections, you want to be very clear about the decisions you made, so that people who are potentially going to use your guideline or adapt your guideline are aware of how you're making those decisions and whether they're appropriate for their setting too.
Yeah, absolutely. Good. Good. So again, you know, we do have research out there. There's not as it's growing again about minimally important differences. But the types of studies you'll see is basically they're asking patients what they think is important. So a lot of times we might think of, say, quality of life, and on a scale of 0 to 10, what's an important change? You know, if my quality of life goes down 1 point, would patients think that 1 point is important? Do they think that 50 fewer women having a missed case is important out of 1,000? So we are more and more seeing more of these studies being published. And at this time, there's a group trying to pull together all of these types of studies about minimally important differences into a database that people could search and find these studies. Otherwise, you are searching in PubMed or Embase for them. Okay, relatively new. One word of caution though is for benefits and harms, we focus on the value placed on the benefits and harms. But let's take, for example, this wording here where it says, from a search of qualitative research, they found many women in the focus groups reported that they did not screen positive for cervical cancer. And the few that screened positive did not have side effects after treatment. Unfortunately, some groups are using this type of research to determine whether people should be screened or not, and using these as the numbers of people who have side effects or not have side effects or don't have cervical cancer. And so we just have to remember, you know, the purpose of qualitative research is not necessarily to provide quantitative results. Qualitative research is really about exploring why people feel they do or how they feel. And not just counting how many people in that group actually had a side effect or not. So just to be careful. If you are using that type of research, which is, you know, to make decisions about how many people would have a side effect, you'll just have to be quite careful, because in essence, it's really just, it's like a case report or case series of those people in the focus groups. So it'll have a lot of high risk of bias, etc. So we just have to be careful about that. Okay. Luba, did you want to go ahead? And I can move the slides for you, but we're going to move into talking about the other criteria.
I'm happy to speak if you're tired of talking, but I'm also happy to just keep facilitating.
Well, please jump in. I can keep going. I have the slides here, and then we'll keep going. So yeah, so I mean, we also talk about acceptability and values, and you know, we talk about values and preferences, but we also talk about acceptability. And I think someone did put it, Luba, I think they did put it in the chat about how people just feel about being screened or not. So it's not about the outcomes. It's not about the value they place on the outcome. It's actually about the physical action of being screened or not, and the acceptability of that. And I think someone mentioned about the cultural acceptability of it, of being screened. So that's it's a different perspective. It's not on the outcomes. It's not on the value placed on the outcomes. It's actually about the intervention itself, the test, the screening, the treatment. And Luba, go ahead.
I just have an example is there could be like an invasive test or less invasive test, and potentially like the more invasive test is more accurate, but then the less invasive test is more acceptable. So you're kind of making a trade-off between like how good the test is and then how acceptable the test is itself. And I also wanted to flag Fabiola has a comment. Some studies show a ranking of outcomes. They could be used for values.
Absolutely. So Fabiola, for values, and sometimes even in guideline groups, you'll do a ranking of those outcomes within the guideline group or even an external advisory group. So that absolutely can be used. And I think in the other chapter where we say about patient involvement and engagement, that's one of the ways that they say to involve patients in the process is actually having them rank the outcomes. Yeah, absolutely. Good. Okay, so I was just going to say that, around acceptability, again, it's the same type of question, study designs that we're looking at. And I just added one more thing to this too, because you can also use randomized and non-randomized studies too. I think we always think about qualitative research, but acceptability can absolutely be measured in other study designs like randomized and non-randomized control studies. So we just have a quick poll. So I put in here 3 different columns here with 3 different evidence results from different study designs. So take a minute to read these through. You can read it. I hope it's clear. And we're going to run a poll to see which one you think would be better to obtain information about acceptability of being screened.
I don't see a poll yet, Nancy. I
No,
don't know
I
if you...
just
okay.
want, yeah, I just want to give people some time to read
Okay.
the different studies. So I hope people had some time to read. So we had evidence from some randomized control trials, some from surveys, and some from focus groups. And we want to know about the acceptability of being screened or not. So I'm just going to run the poll, say which, choose which one you think is better. And then we'll have a little bit of a discussion about why or why not. So let's just see if this poll will actually go. So let's launch this poll. And Luba, I'm not sure if you can vote. Can you, can you?
Turns out I
vote?
can't. Yeah. At
Okay, I
first
didn't
was
think
like, what's
so.
going on? Yeah, because I'm co-host, I can't vote.
Okay. So we've had quite a few people, pretty close to almost all of us who was able to vote. Yeah. Great. Okay. Okay. So I'll end the poll. Hopefully we can see the results. But I'm going to keep in my head just in case. Maybe I'll take a screenshot just in case it doesn't work. So, hold on. Okay, so I'll end the poll. Okay, and I'm going to share the results. Okay, can people see the results?
Yes.
Okay, great, good, good, good. So we had it's somewhat evenly distributed between the randomized surveys and the qualitative research, and then we had a few more people say that they would say all of them. I'm wondering why did some people not choose the randomized control trial? What was it about that maybe wasn't so as so good, was the best evidence? Okay, Jacob, right away, what would you say?
Yeah, so I was having trouble, but I knew so I was thinking at first RCTs because that is the gold standard for, because the researchers are blinded and they're placed randomly and you're able to control. But then I thought, well, it's easy to meet the internal validity, but the external validity, kind of like the generalizability, I think it's always tricky to assess even in RCT, because you can't, there's some ethical considerations and, having people being put in certain conditions. So at first I was a little bit more so RCTs, but I also want to appreciate the other evidence, making that combination, knowing in my head that the RCTs are like, the top, but then considering the other evidence too.
Right. Yeah. And I think, you've totally hit on a few of the issues. We always think, oh, randomized control trial is the best. But of course, there are still biases that can happen in the randomized control trials. It may not be representative. And so we still need to assess that evidence. One of the great things about the randomized control trial, and I think maybe, yes, was it, I'm not sure, it just says quality department, but I'm not sure who that is, but it's the great thing possibly about the randomized control trial is we definitely have people in one group who received screening and people in the other group who didn't receive screening. And technically, if it's a good randomized study, those people would be the same. They would be similar people. And so we would know that, well, it's not because people were younger or older, or people were from a different SCS versus another. Technically, those people should be quite equivalent, and the acceptability that we see would be accurate. Still, randomized control trials can have problems, but one nice thing is we have two groups that are pretty similar. One didn't have screening and the other one didn't. Okay. Some people said the surveys were probably the best. I don't know if anyone wants to volunteer why the survey might be a good one, or why they didn't choose the survey.
Sorry, Nancy, I just wanted to add the quality department person, apologies though we don't know your name. I think what they were getting at was that in order to be part of the trial, they had to already be okay with screening.
Screening to begin.
So probably the reason why it's 70% acceptance is because they would have had to been okay with it to enroll. I'm actually surprised it's not higher than that, but interesting.
And it's also 70% in the other group too. The 70% said it was okay not to be screened.
But again, you'd have to consent to be randomized to either option.
To be participating, yeah.
So otherwise you would, if you had like a lower acceptance rate, you wouldn't even be part of the trial.
Okay, so any comments about the surveys part? Why or why not?
Nancy, I just want to be mindful of time. We've got 13 minutes left.
Sure. So one of the points, and I'll say is one of the points about the surveys is this was only a survey of women who were screened. So we don't actually know about the women who were not screened. So that might be something. And then for the focus groups, we had quite equivalent. Focus groups, the nice thing about this were focus groups were in people who were not screened and people who were screened. So that's great. Typically doesn't happen that way. So we have both groups. And just remembering the type of information that we usually obtain from focus groups is, of course, from the qualitative research is more about why they liked screening or why they didn't like screening or miss not having screening or how they felt and their perspectives of when they were screened or when they weren't screened. So just remembering, all of these studies can provide information. It's just remembering what is the type of information that is more appropriate to come out of qualitative research or from a randomized controlled trial. So it really is different types of information that can come out of those different study designs. Great. And so what I did is I just summarized these on the screen here. Some of the biases that can happen from qualitative research and also some of the biases that can happen from comparative studies too. So just really the same issues that we all brought up. So that's great. Okay, good. So the other criteria, we just wanted to make sure that we did cover feasibility, equity considerations or costs and resources that are involved. And again, the type of study designs, again, we would just highlight that you can obtain this type of information from any study design, really. The main issues are what type of information we might look for from feasibility interventions type studies, for example. And I think, just given the time, we might just consider just putting in the chat some ideas of what type of information we could obtain for feasibility or equity or costs and resources. So if we're thinking about screening, for example, what information could we obtain from patients and the public around feasibility or some equity issues or costs and resources? So Luba, Luba, you put in willingness to pay. Yeah, absolutely. So to pay for a test, if they had to pay for a test or not. Yeah.
I will say that even though willingness to pay is like directly supposed to be cost related, it is still used as kind of like a preference adjacent kind of value.
Yeah.
So like presumably people are like willing to pay more for things that they want. But even though that's not always the case, and especially when you do a willingness to pay study in a place with like public healthcare, like it's a lot harder to kind of like understand what people are thinking.
Yeah. And Janice, put, ability to pay. Yeah. So this is also another fine line. Yes, absolutely. Jacob, absolutely. The time it takes to get to the clinic, the time to take off work to go and be screened. Absolutely. In general, additional visits or providers. Absolutely, though. But this is true for this one. Many times in the guidelines, we're looking at doing screening and treatment in one visit because we know that multiple visits can be difficult for some people. So excellent. And differing levels of access to screening. Absolutely. So it's interesting, and this is what generally happens. A lot of people, when they're looking for information about feasibility, equity issues, costs and resources, there's a lot of overlap. And I think let me just make sure. I think I put that in the next slide. There's a lot of overlap in the type of information around feasibility, costs, and resources because something may not be feasible because you can't afford it. We may end up having some equity issues because someone can't afford it because of the costs of the test. So these are very much overlapping, but I think the key point here is that looking for studies, again, similar types of studies, and also just recognizing that you may look for studies for values and preferences or feasibility, and find that you're also obtaining some information about equity issues and costs and resources. So something to, when you're abstracting data from those studies, to be alert that you may, actually when we do our extraction, we have columns for all of these areas, because typically one of those studies will provide a lot of information across all of these issues. Yeah, so access to, I'm just looking at the last few points about information about harms and screen. Yeah, absolutely. Rural costs, transportation, absolutely. So again, feasibility, costs and resources, equity, they do overlap quite a bit. Great. So just, we have about 7 minutes left. I didn't want to go into too much detail, but how are we going to find this information? And I always suggest we do it in our group. Luba, I'm sure you do it in your group. We always look for someone else's work. We always look for someone else's systematic review of the literature. And we'll also look at other people's guidelines where they may have done a systematic review of the literature, but just didn't publish it in PubMed, for example. But within the guideline, they do have a review that was done. Yes, reduce waste in research. So looking for someone else's work, absolutely. So in the GIN Public Toolkit, in that chapter, we do have a list of where you could go and how to find that literature. One of the places, as I have kept mentioning, is our traditional databases. Absolutely, PubMed, Embase, Medline. And also in that chapter, we do provide some ways to try and find systematic reviews or other people's guidelines. So for example, you could look on the Cochrane Library, or Epistemonikos is another database that pulls together systematic reviews. And if you're looking for guidelines, there's the Guideline International database, and also the TRIP database for guidelines. So again, you're looking at someone else who's reviewed that literature. And also within the chapter, if you're interested, if you're going to do your own review of the literature and you're going to look for specific studies, there are quite a few groups that have decided and spent time developing search strategies to find how to find patient views, feasibility, values, acceptability, etc. So those are also in the toolkit and available with links to those. Okay, and then finally, this sounds like a lot of work. It always does. But what we've done in the toolkit is we've just emphasized what you as a guideline group or as a guideline organization might think about when deciding whether you're going to do this big search, whether you're going to look for feasibility, equity, acceptability, patient values. You're going to look for priority questions. That can be a lot of work. And most of the time, it's limited because your resources are limited. And we've also pointed to other reasons where you might or might not do all of this work. I think Luba and I, when we did this chapter, we really thought that the most important decision-making factor when deciding about what you were going to look for and how in depth you were going to look really was about whether the group, the guideline group, and you as an organization would have the most impact in the decision making. So if you think that values could be very different and need to be researched and we really need that literature, then you would spend the time looking for evidence and research around values. If you think that the patient perspective on equity was super important, then you might do a search just on equity, for example, and spend the time there. So again, it was really, we would go back to the guideline group and say, where do you think we would have the most impact? Patient perspectives would have the most impact, because that's where we're going to spend more of our resources. So we just have a couple more minutes left. I'll leave this on the screen, but just wondered if there were any final burning questions that people had that they wanted to share before we finish.
This is Janice, and I forgot to mention at the beginning that I'm a public member for the people that don't know me, and serve on the American College of Physicians guidelines panel currently. And I just want to add that what I've really has come to the forefront of my thoughts regarding patients and public involved with guidelines, and really this last year, is the importance of qualitative research and how it helps to inform the study, right? So it should be done at the same time as when you're looking at RCTs and systematic reviews. And, I originally took like guidelines training many years ago, 215 or something, evidence-based guidelines affecting practice policy, stakeholders, New York Academy of Medicine. And I, everybody emphasized RCTs, but then I heard about, well, we need qualitative research. It's the same circle going around and around and around. And I myself found RCTs are the best, whatever. But then working in RCTs directly in projects, I realized where the biases are and how important having, a patient or public voice in the formation or the design of the protocol of those RCTs, because it really helps to bring relevance. And you don't always find if individuals were involved in the older RCTs, right? So anyway, we're moving in that direction, but qualitative research and surveys, focus groups can help to inform outcomes and values and preferences.
Yep, absolutely. Great point. Yep. Yeah, we definitely need this research and patient perspectives, and it can come from any type of study design. Absolutely. Good. Any final comments or points anyone wanted to make? I'm pretty sure this was a recorded session. What I'll also do is put my because I'm happy to share the slides. Luba, I think we're absolutely fine, but if you did want to contact me for just the slides and not necessarily the whole presentation, I'm just putting it in the chat. Please feel free to contact me and I can share the slides. But again, the GIN, and I'll just make sure the link is there. Hold on, see if I can exit. The link to the toolkit. Let me just make sure. So so I'll just type it in there. It's the link to the toolkit is, I think I have it open here. So you'll have a lot more information there. From the toolkit, and we just touched on a few spots. Great. Excellent. Well, thank you everyone for joining, and also thank you for participating. It's really great when people are contributing to the chat, and hope you have a good evening or rest of your day. And again, I think this will be available also on the GIN website, the recorded version. Good. All right. Thank you so much, everyone.